So Dr. Bryant, he hails from New Zealand, kind of down under, and he went to medical school in New Zealand and then went through his residency, correct me if I'm wrong, in Milwaukee. And then he came to Utah for the love of snow, where he and his wife are avid skiers, it sounds like. He has obviously lots of experience in critical care and social media, and that's what he's here to speak to us about today, is the use of social media in medical education.
All right, thanks, Daniel. So social media in medical education. The one takeaway point that I give to most clinicians that I give this talk to is that this website is probably the most important website for them to use, www.foamsearch.net. We'll get on in a little bit to explain what foam is and what it means, but for clinicians, this is the key website that I like them to be aware of. The other title that I like to give this talk is that you need a butler and a bulldog to help you navigate the waters of the social media realm. I trained in Milwaukee, as Daniel said, finished up in 2004. Milwaukee was a great residency program, had some pretty good cocktail bars. When I finished residency, I'm not going to say that I was God's gift to emergency medicine, but I kind of had it going on. I could intubate people with a Mach 3 and a Mach 4 blade. I'd given high-dose steroids to people with spinal shock and spinal cord injury that we no longer do. I'd given Nasiratide to sick people with CHF that we no longer do. I could do a fast exam, I could do a bedside ultrasound. If you were to assign a physique to my brain when I finished residency, it was something like that of a 1970s Arnold Schwarzenegger. Moving to Utah in 2004, a couple of good ski seasons, a couple of young kids, and then basically no reading and no active pursuit of educational endeavors for 6 to 7 years led my brain to fatigue a little bit. And it took on the physique of this guy, fat bastard from the Austin Powers movies. It was bad enough with the transformation that I was able to perform on my brain's physique from those hellaciously overweight brain days to where my brain is now with the use of these social media tools is best described by one of my former residents, Carl Seeger, who was there for the fat bastard days and then came back a couple of years ago and worked a few shifts with us. And it was mid-shift, and Carl turned to me and he said, "Is that playing?" He said, "Did you get sued or something? Because when I was a resident, you weren't that, smart." He's right, I wasn't that smart. What I'd like to do today is show how these FOAMed tools, these web-based, free, open-access medical education tools, can help maintain the Arnold Schwarzenegger physique of your brains, or help take those fat bastard brains and improve the physique of those brains to something resembling Arnold Schwarzenegger. I'm going to talk about and describe FOAMed. I'm going to talk about and describe the tools that are used in social media and education. I'm going to describe Feedly and Twitter as ways to filter the online open access medical educational options that are available and show how these are useful, and ideally show how your conference attendees may be using these in the middle of a conference and may be using these to better prepare for your conferences. And the end goal of ideally realizing that podcasts are useful and having some clinicians actually load podcasts on their phone and use them, have you consider getting Twitter accounts, and have you realized how useful Twitter can be as part of a conference plan. So FOAMed, let's first describe that. FOAMed is free, open access medical education. It's basically any online medical content that is freely available. Mostly it's comprised of blogs and podcasts. We call it FOAM, or FOAMed, medical education, because the label foam is already taken. If you Google foam, you're going to see pictures of ecstasy-laden 20-something-year-old trust funders having pool parties. So FOAMed is the hashtag, not foam. So foam resources, there's about 200 to 250 different online resources available, either blogs or podcasts, mostly in emergency medicine and critical care, but there are radiology, anesthesiology, and other specialties that are late to the party that are starting to catch up. So I want to review some of the better emergency medicine and critical care blogs and podcasts first, and then we'll move on to show how Twitter works. So the Mac Daddy, the granddaddy of emergency medicine blogs and critical care blogs, is this Life in the Fast Lane website. It was the first true critical care emergency medicine website focused on education. It's effectively an online textbook. It has a couple of great things. Each week they release a Life in the Fast Lane review that takes the top 10 to 15 pieces of FOMED medical education from those 250 different blogs and podcasts and gives you a top 10. So you don't even have to have a Twitter account or be actively involved. You can just get an email or see that this website has released their top 10 to top 15 list and scroll through those to see what's interesting. They also have a phenomenal EKG library that I can use on shift to improve the care that I'm delivering and improve the education that I'm offering my residents. Academic Life in EM is effectively an online medical journal. They have raised the bar significantly of what constitutes a quality medical blog post, to the point that they have pre-publication peer review with an expert in that field, so that when the blog is posted with references, it's already been reviewed by an expert in that field, and has open comment section so people can give immediate feedback. It also has a selection of paucis verbis critical care cards that we can consult on shift, and also forces me to learn about and read topics that I ordinarily might be less interested in terms of educational issues, professional issues, and some pharmacology topics that I wouldn't independently seek out or search out myself. This Trauma Professionals blog is written by Michael McGonigal, who's the Chief of Trauma Surgery for Regents Hospital in St. Paul, Minnesota. So he's the chair of their department. He has his own blog. Anything he reads that's worthwhile or worth listening to, worth reading, he will comment and review on his blog to say this is a great article or this was not a good article and here's why. Moving on now to podcasts. The best critical care educational content available in the world is this MCRIT podcast. It's run by this guy, Scott Weingart, who's an ED intensivist in New York City. His goal is to bring upstairs care downstairs. Now, since listening to this podcast since 2011, I've become more competent, confident, and continent in critical care scenarios, to the point that I've gone from someone that my nurses would push past looking for a physician that can help their sick patients to someone that my nurses will actually be happy caring for their sick patients. Carl Seeger weighs in again on this and says, "So Rob, you don't actually believe in all this Scott Weingart bullshit, do you?" Actually, Carl, yeah, I do. It's helped me become a better, more competent physician, and I tell people that I probably save 5 more lives per year since listening to just this podcast and incorporating some of the recommendations into my practice. 2 homegrown, Utah-educated emergency physicians, Mike Mellon and Matt Dawson, started the Ultrasound podcast 5 years ago now, and it's held up as the world's best ultrasound educational tool. Their catch call is that we're going to make bad doctors good and good doctors great, and their teaser to incorporate more people to listen to their podcast is saying, if you look around your department and you can't tell who the bad doctor is, it's you, and you need to listen to our podcast. The SMAC conference is now in its 3rd year and is the world's best critical care conference. It's grown from the community of FOMED users and FOMED producers, and the talks they deliver are phenomenal. They're all TED-style talks with phenomenal educators, phenomenal slides, and phenomenal delivery. If you're unable to attend this conference, which sold out in 6 hours when they released the 2,000 tickets a couple of months ago, they release their talks for free over the following year, so people still have access to the content that they are offering. The benefit of podcasts is they can be pushed to our phones. We don't have to go out and actively seek out and search out this educational content. We have either all become busier or lazier, so it's easier for this content to get pushed to us rather than to go and seek it out. So if you have a podcast application on your phone, instead of listening to NPR or any of the other non-medical, less useful podcasts, we can use educational podcasts. And I'll listen to these driving to and from work, waiting in line for my coffee, or anytime I have any downtime, or anytime I'm forced to spend time with my in-laws. Some of the feedback we get from traditional learners is that there's potentially poor quality with these online resources, and that there's no peer review with these online resources. Interestingly, there's probably a lot better peer review with these online resources than some traditional medical content and some traditional conference presentations. The reason for this is that on the internet, people fall over themselves to prove that people are wrong. And in medicine, some specialties take great pleasure in pointing out when someone is incorrect. So when we combine the eagerness of people online to prove someone's wrong with the medical eagerness to prove people are wrong or to educate them, we get a perfect storm of rapid, good feedback. I wrote this blog post on the Rebel EM website a couple of months ago about post-intubation sedation for pregnancy patients. I'd intubated a pregnant patient who was in her 3rd term. I'd never intubated a pregnant patient before. I had no idea what post-intubation sedation to use for this patient. I didn't know if my normal medications, fentanyl and propofol, would be safe for that patient or for her fetus. I made an error and had the wrong microgram per kilogram per hour dosing instead of microgram per kilogram per minute dosing on my propofol and ketamine dosing. Within 15 minutes of this blog post being posted, I got a message through Twitter from someone in Canada questioning the units of the medications I was recommending. We were able to immediately fix that and post a message on that blog saying, hey, we've fixed our error. If this was in a print journal, it would take months to sometimes years to actually fix that and get that error corrected. Scott Weingart of the MCRIT podcast says that he gets better feedback on his website than he does from his published journal articles. And he's a world-renowned educator and has published extensively, so is able to make that comparison. The other thing with content and quality is that readers will typically vote with their mice. If someone is posting poor quality content, or poorly referenced content, or erroneous content, then people aren't going to read that. So there's going to be less traffic, and there's going to be less people sharing those podcasts and sharing those blog posts. A recent article in Annals of Emergency Medicine, which is the leading emergency medicine journal, took all of the leading FOAMed producers, blogs and podcast authors, there was about 20 of them, and had them weigh in on what they felt went into high quality content. And they basically said that anything that looks good on a website, that is factually correct, that is free of grammar and spelling errors, that is well referenced, and that is open to feedback is going to be high quality. So they're basically describing something that is prettier than a traditional journal article that gives you better access to the authors and producers of that content. All of the people that produce this FOAMed content tell people to do their own reading. They tell them to trust no one. It's not an excuse for people to lazily listen to a podcast and then start doing something without actually doing their due diligence. These blog posts and podcast talks are no different than a standard conference presenter. I'm not going to go to a conference, have someone present something completely new to me that sounds good, and go and blindly start doing it without actually doing the reading, checking their references, and seeing if it truly works. Mel Herbert of the MRAP podcast, which is a paid subscription podcast, recommends to never be the first or the last person to use a new treatment, drug, or technique. If I have a resident come to me, or if an attending who doesn't use these social media tools has a resident come to them and say, hey, I heard this on the MCRIT podcast, let's try this, they're going to have significantly less credibility than if the resident says, I heard this on a podcast, I've read the literature, here's my well-reasoned, evidence-based rationale for trying this technique, let's try it. So same idea, same intent, but some of the younger learners, the millennial learners, probably need to be a little careful in terms of how they describe their intent and where they sourced their new information to the gray hair or no hair generation that they're working with. So again, we should consider these FOAMed resources equal to a grand rounds or conference lecture in that it may sound like a great idea, the person may be really enthused about it, but we still need to do our due diligence and still need to read. I've described 200 to 250 different web-based educational features. That's a massive amount of information and pales in comparison to the massive amount of print journal media that is published. So we need a filter to be able to break down this massive amount of information to know what's truly going to be useful to us. We basically need a butler to deliver these small pieces of foam to us. One way is to use a blog aggregator like Feedly, and this is basically like the old school magazine subscription papers. Anyone that's over the age of 40 will, like myself, will remember actually checking, yes, I want to read People, Yes, I want to read Time. No, I don't want to read VQ. No, I don't want to receive the New Zealand Woman's Weekly. So you're getting specific blogs and podcasts sent to your blog aggregator. It's kind of like a personal newspaper that you can look at when you're in line for your coffee, when you're waiting to pick your kids up from school, and you can see what's new and fresh. The limit to this is that you're stuck with those magazines that you chose. If there's something awesome in the New Zealand Woman's Weekly, you don't have access to that because you haven't subscribed to that. So that's where Twitter is a little better. I'm going to spend a few minutes describing the benefits of Twitter and how it can actually be used usefully rather than used to provoke hate in the way that Donald Trump uses it. So there's a growing body of literature showing that Twitter is useful as a tool for communication and knowledge exchange in academic emergency medicine and academic medicine across the board. The initial users, similar to the podcasts that we've described, have been emergency medicine and critical care physicians. Twitter use is expanding now to the point that the American College of Surgeons has live Twitter feeds and has people saying, yes, you can tweet my slides and yes, you can tweet my talk when I'm delivering this talk at our annual meeting. The urologists are in on this, the ophthalmologists are in on this, even the radiologists are in on this. The major way that I use Twitter is to crowdsource my evidence-based medicine updates. It's really hard to know what's worthwhile and what's useful to read with the thousands of articles that are published every day. Most people will have two flavors of people in their departments, regardless of their specialty. These two people will come up to you and say, hey, you've got to read this article. It's awesome. One of those people will be super smart, well-read, and is a reliable, credible source, and it's going to be worth reading what they suggest. The other person may be less well-read, may make poor choices or be known to make poor choices medically and socially, and they're going to be a less reliable and less credible witness when they tell you that you need to read something. So what I effectively am doing is crowdsourcing my recommendations and taking that smart, reliable person in my department and taking the smart, reliable person from every single intensive care unit and emergency department across the world and getting their input on what I should read. Not only are they able to send out links, PubMed links to the abstract of these articles, they'll also send out saying, hey, here's this new article, we've been waiting for it for a while, it was total garbage. Or they'll say, here's this new article, it is perfect. Or I can see experts weighing in and kind of having a to and fro on Twitter or on their blog post about these articles. This allows me to cheat a little bit, so if a resident comes up to me and says, hey, I just read this article about blah, 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 I can say, yeah, I'm aware of that article. Maybe I've read the abstract from a link that I saw on my Twitter feed, and I can say, here's what I think, either having read the article or cheating and paraphrasing those experts that I know their opinion of, or I can say I'm aware of this controversy. It also allows me to have better access to some of the literature that my other specialties are using. In emergency medicine, I need to know the recent literature in urology, cardiology, neurology, trauma surgery, general surgery, gastroenterology, everything. I need to know about the first 15 minutes of every disease process, and it's really hard to keep up on everything. The other benefit of Twitter is virtual conference attendance. Traditionally, people go to a conference, spend several $100s worth of airfare, several $100s worth of hotel fees, and several $100s to attend a conference. Those people that are sitting in that conference would traditionally take notes, maybe write down 4 sentences for each talk of the salient points. If we take those note takers and put them on Twitter, they can send out a tweet of what that person is delivering, of what the speaker is delivering. Most speakers are okay with this because it allows their content and their brand to get shared on a wider platform. So now, if there are helpful people live tweeting talks, sitting in the conference, taking pictures of relevant slides, sending out the pearls from those talks, I can be watching this conference from the comfort of my own home, in my own comfortable clothing, and I can benefit from that conference virtually. The other thing that can happen is that you can get people from the other side of the world send in a question via Twitter to the speaker. At the SMAC conference, they didn't have live questions after a Q&A. They didn't have a live Q&A session after each speaker. They had a Twitter moderator, and the only way you could ask a question is to tweet in a question. That question is limited to 140 characters. For conference organizers, I'm sure you've experienced someone getting up and delivering their own talk loosely disguised as a very, very long question. So it eliminates the personal speech and personal interjection and long sub-talk that someone wants to deliver but didn't have the opportunity to deliver at your conference, so it can tighten up that Q&A period at the end of the conference. Most conferences will have hashtags, which is essentially a topic of conversation that is a searchable way of seeing what's happening in that conference. So hashtag ASAP TF14 is the ASAP Teaching Fellowship. Essentials of Emergency Medicine is one of the better emergency medicine conferences. ASAP 14 is American College of Emergency Physicians, 2014. So ASAP 14, ASAP 15, ASAP 16. A hashtag is just a topic of conversation. Suppose you're at a party, it's a work party, it's not that much fun, you're talking shop with your colleagues, and you would much rather be talking football. You're going to have an ear out to hear if someone's saying Super Bowl or Packers or Vikings or Utes or Cougars. And the minute you hear that topic of conversation, you're going to try to excuse yourself from that conversation and get in on one that's more fun. So that's basically what a hashtag is. Twitter use in conferences has grown exponentially. In 2011, the Society of Academic Emergency Medicine Conference had 30 people tweeting that conference. The SMAC conference I just attended in Chicago had 5,000 Twitter users. There were only 2,000 people at the conference, so this includes people participating in and using that conference from the other side of the world. 80,000 tweets were sent out. Things I have learned from not attending the ASAP Teaching Fellowship: don't show pictures of your family during a presentation. Nobody cares. You're welcome. Don't interrupt a medical student or resident's patient presentation in mid-history. They hate that. So I've helped several hundred people by not boring them with pictures of my dog or my family, and I've helped several medical students and residents by being a better educator from learning these specific teaching pearls. I want to review briefly how Twitter works. Every Twitter user has a handle. It's the @ something to do with their name or @ whatever you want, usually a recognizable title. You've seen on the news presenters or sports commentators will all now have their own Twitter handle. These are the number of people that I follow. These are the people that follow me. Anytime I send a tweet, these 1,000 people have access to seeing that tweet. A tweet is a 140-character sentence that you can also embed links to articles, links to websites, and you can tag other people into that discussion. Twitter is not Facebook. Twitter gets a bad rap because of people like the Kardashians. Twitter is the vehicle that allows this communication to occur, that allows this live tweeting of conferences, that allows this crowdsourcing of evidence-based medicine. Hating Twitter because of the Kardashians is kind of like hating libraries because there's books on paleo diets in them. We don't want to hate the vehicle, we want to respect that it can be used appropriately. So I use Twitter to break down this sea of foam into smaller bite-sized chunks. Twitter is my butler. So we've discussed a butler. Now we want to describe briefly the purposes of a bulldog. We know that all this great educational content is out there. We need a way to go out and search for that content. The way to do this is using this website, foamsearch.net, which is a custom search engine that deliberately searches those 250 different blogs and podcasts. So an example of this, if I'm on shift working with a resident, we've just resuscitated a patient who's taken a massive beta blocker overdose. One of the novel but very effective treatments for this is to give super high doses of insulin. 1 unit per kilogram bolus, 1 unit per kilogram per hour drip. Ridiculously high doses. It works really well some of the time. Supposing my resident asks me one of those really annoying questions. Hey, how does high dose insulin work? I can either waffle on for 5 minutes and say there's some magic there, there's something to do with cyclic GMP, maybe there's some insulin channel effect, maybe there's something to do with these certain pressors, and I can waste 5 minutes of my time and 5 minutes of the resident's time trying to waffle my way through an explanation and finish it with the ever helpful, does that make sense, to which they have to say yes to escape the conversation. The other thing I can do is say, I know that I've heard a great podcast on this. I know that I've read a great blog on this. Let's use foam search and search this. I look up high-dose insulin and beta blockers. I see a post from the MCRIT podcast. I remember that they talked about both calcium channel blockers and beta blockers. Maybe I haven't heard that podcast. Maybe I know that the MCRIT podcast is a reputable educational resource. I go to this website, I tell my resident, listen to the podcast, read the article they've referenced, and let's talk about it on shift the next time we work. I can scurry away, listen to that as well, read that as well. I get to up my learning so that if someone in between times asks me a question about high-dose insulin, I can pretend to have known that all along, and I can also test whether my resident's actually doing the due diligence and going and doing that reading. Again, from Annals of Emergency Medicine, they've reviewed 5 strategies to effectively use online resources in emergency medicine. They review most of what we've talked about here. Getting an RSS feed, or really simple syndication reader like Feedly to collate the resources that you like, using a podcast application so that these podcasts are pushed to you, using compilations like Life on the Fast Lane, that will help bring that content to you if you don't want to jump into the Twitter ocean or you don't want to get too involved in the social media world, and then using custom search engines like Phone Search. Some millennial learners will say, this is awesome. Does this mean I don't have to read anymore? Absolutely not. There's still stuff, usually the really, really boring stuff of most specialties, that's hard to make sexy, it's hard to make it entertaining, and it's hard to deliver it in a conference format that has to be learned. So we still have to learn, and learning is supposed to be hard. Our brains are complex, and it's hard to get information into our brains and to make it stick. Brief shout out to professionalism. Clearly, it's really easy to do bad things on the internet. I typically recommend to my residents that they never post anything that they wouldn't want to see on a freeway billboard driving down I-15. I've learned a lot of great clinical pearls from people not exactly live tweeting their patient encounters, but sending out pertinent pieces of information related to patients that they've seen. Because a timestamp or the day you see something rare and weird and freaky counts as a pertinent piece of patient information. If I see something awesome on a Monday and want to share that pertinent clinical pearl on that patient, I'll typically send out a relevant article related to that on a Tuesday and not include any clinically identifiable information with that patient. The other thing with these social media tools is that anyone can see who you follow. If you're applying for a new job or a fellowship anywhere, you're pretty easy to Google. People can find your Twitter account and they can see who you're following. And they can come up with a pretty rapid opinion of who you are and what you're like and what your political beliefs are like. So I suggest taking care with any online platform, whether it be Facebook or Twitter or anything you're posting, and realizing that anyone can find anything that you post online. It's important to own your own your online profile, because if you're not in charge of it, someone else will be. So in summary, these FOAMed tools are phenomenal and have helped take me from a fat bastard brain to an Arnold Schwarzenegger brain. They're useful. It's important to know that it's not Facebook, it's not Kardashian-esque, and it is a legitimate way of learning. To best summarize this, I want to quote Joe Lex, who's basically the godfather of foam. Joe Lex is such a great educator that the American Academy of Emergency Medicine has named their Educator of the Year award the Joe Lex Award. He says, if you want to know how medicine was practiced 10 years ago, read a textbook. If you want to know how medicine was practiced 3 years ago, read a journal. If you want to know how medicine is practiced today, use FOAMed resources. So we need a butler to bring us this content, and that can be Twitter or Feedly. We need a bulldog to go out and find content that we know exists. And it's important to realize that the FOAMed train has already left the station. It's reasonable to get on board or to be aware that you will have people attending your conferences that are using Twitter effectively, are using Twitter helpfully, and that your speakers may also be using Twitter effectively and helpfully, or that if your speakers are asked if people can live tweet their talk, that it's not plagiarism and that it's helping the greater medical community. Thank you.
Okay, thanks so much, Dr. Bryant. That was a great, very fun-filled talk. If there are any questions for Dr. Bryant, you can always email us those questions and we can forward it on to you and connect you. You can also follow him on Twitter. What's your handle again?
It's at RobJBryant13. At RobJBryant13.
Okay. I just think this is a very timely talk for us to start our 2016 webinar series on with educational events moving forward in the years to come and a new generation of communication. We might, not might, I'm sure we will be seeing much more of things like Twitter as a means to educate our target audiences.
And to follow up on that, I want to highlight that we did at least have a super user following along with my talk. Brian McGowan, at Brian S. McGowan, was actually live tweeting my talk while I was delivering this. So it's thank you, Brian, for displaying proof of concept for how this works.
Okay, thanks so much for attending, everyone. And we will see you in February 9th. From 12 to 1 for our next webinar.